Thank you so much, Dr. Katz. Our next presenter is Dr. Keyanoosh Hosseinzadeh. He's Chair of Education at the VA in Durham, North Carolina, and the Deputy Editor for our GU section in RSNA Case Collection. He'll be showing some interesting GU cases.
Thank you, Richa, for the introduction. Let's move on to the first case. So the history here is preoperative assessment prior to liver transplantation. We have a grayscale image of the right kidney and the corresponding color Doppler image. Spend a few seconds here. And then based on this ultrasound, decision was made to order a renal mass protocol CT. So let's move on to the next slide. So here we have a series of axial images at the same level, different time periods. The top one is corticomedullary. The middle one is sort of middle in between corticomedullary and nephrographic. And then the last one at the bottom is the nephrographic/excretory phase. And then we have an NPR image, coronal NPR image on the right. So let's spend a few seconds here. Let's move on to the next slide. So what is the diagnosis? Solid renal tumor, dromedary hump, hypertrophied column of Bertin, or focal area renal cortical hypertrophy next to a scar. So look at these images, start with the ultrasound, and then move on to the CT. Okay, let's move on to the poll. Let's trigger the poll. All right. Looks like the majority have gone and voted for hypertrophied column of Bertin. 6% feel that it could be a solid renal mass. Certainly could be on the ultrasound. All right, let's go on to the next slide. Yes, the majority is correct. This is hypertrophied column of Bertin. So let's move on to the next slide. So what is hypertrophied column of Bertin? So hypertrophied column of Bertin was first described by a French anatomist, Monsieur Bertin, otherwise known as a junctional parenchyma. It's a renal pseudo-lesion, so it's not a true tumor or neoplasm. It's mass-like. What is the column of Bertin? So a typical adult kidney is formed by the fusion of around 14 subkidneys. And these subkidneys, when they fuse, they usually fuse on an end-to-end fashion, and the intervening parenchyma, which is called polar parenchyma, that resorbs. Now, if that fusion doesn't occur in an end-to-end fashion, that intervening polar parenchyma remains, okay? And that then forms a hypertrophied column of Bertin or a junctional parenchyma. So it's a variant of normal. It's not true hypertrophy, so that's a misnomer. It's just a variant of normal, but this term is being used to describe this anatomical variant. So what do we see on imaging? On ultrasound, these masses are typically hyperechoic. And why is that? Because of the anisotropic effects of the beam on the tissue interaction itself. It can be isoechoic as well, but typically hyperechoic. So you're forced to order a CT or an MR to clarify this. And what do we see on CT in this case? And depending on the plane, you'll see this best in one plane or another. You'll see extension of cortical tissue into the renal sinus. And it should contain the pyramids as well. Now, this can involve either kidney equally, and it's important not to confuse this with dromedary hump, which is a prominent focal bulge, supralateral border of the left kidney, and it's caused by splenic compression, chronic splenic compression. So this is hypertrophied column of Bertin. Let's move on to the next case. Case 2, 53-year-old woman presented with abdominal pain and bloating. We have an axial image. Let's have a look. Let's move on to the next slide. So here we have a coronal NPR on the left, and we have a single shot fast echo / haste image or T2 weighted acquisition on the right. Ignore the right renal lesion. This was just a hemorrhagic cyst. All right, so what's the diagnosis? So the diagnosis, possible considerations: ectopic adrenal tissue, horseshoe adrenal gland, discoid adrenal gland, and polysplenia. Have a look again at these images. Let's go to the poll. Okay. Looks like the overwhelming majority is selecting horseshoe adrenal gland. And the answer is, next slide, yes, horseshoe adrenal gland. So what is a horseshoe adrenal gland? Let's move to the next slide. So a horseshoe adrenal gland is also known as a butterfly adrenal gland, depending on which plane you're looking at the adrenal gland. So this is a midline fusion of normally paired adrenal glands. They typically occur anterior to the abdominal aorta. It's important not to confuse this with a discoid or a pancake adrenal gland that you usually see in association with renal agenesis. It's extremely rare, congenital anomaly, and it's usually discovered incidentally, but is associated with vascular, vertebral, and solid organ anomalies. So here I've shown you two anatomical variants. So there's no true pathology here, but there are also important diagnostic considerations to make when reviewing GU anatomy or pathology. Okay, thank you very much for your attention, and let's move on to the next speaker.
Thank you so much, Dr. Hosseinzadeh. That was great. Our next speaker is Dr. Cynthia Wu, who's Associate Professor of Neuroradiology at UCSF, and she'll be introducing or reviewing some interesting neuroradiology cases. Thanks, Dr. Wu.
Thank you so much, and thanks again for attending our session. And let's move on to some neuro cases. So this is our first case. Here's a 2-year-old pediatric patient who presented with 3 weeks of neck swelling. You can see here we have a sagittal midline MRI image in T2 weighted image, as well as an axial T1 fat suppressed post-contrast image through the level of the floor of mouth. And you can see the pertinent finding here. Let's go on to the next slide. Here we have, again, axial images through the floor of mouth. The first one on the left is T1 pre-contrast, and the one on the right is T2 with fat suppression. And next slide, please. Here we have diffusion weighted image and ADC map correspondingly, again, in that floor of mouth level. Let's go on to the next slide. So our choices are thyroglossal duct cyst, lipoma, lymphatic malformation, and sublingual dermoid cyst. Which one do we think this is? Let's go on to the poll. All right, we're getting some answers already. Great. And give it another second here. We're seeing a little bit of extra answers. The vast majority of folks seem to go for a sublingual dermoid cyst. And we have someone chatting in as well. All right, let's go on to the next slide. And indeed, the answer here is a sublingual dermoid cyst. Next slide, please. And what we see here is the sublingual dermoid cyst, like dermoid cysts anywhere else, arises from a ectodermal rest that is in essentially the wrong place. And being a dermoid cyst, it contains structures from all layers of the dermis, and it usually has some lipid or fatty components that comes from the sebum that you have in your dermis normally. So this is not true adipose tissue. This is sebum coming from those sweat glands that are in the dermis. And in the floor of mouth, what we generally see are these classic sack of marbles appearance that you can see highlighted here with these yellow arrows. And traditionally, this was actually described by an ultrasound. And what it is all those pieces of essentially lipid and intermixed with liquids and creating that heterogeneous appearance. All right, great. Let's go on to the next case. So case 2 is a little different. This is an older patient, 68-year-old woman with a history of rheumatoid arthritis, hypertension, osteoporosis, and comes in with recurrent bilateral parotid enlargement over years, and it started 8 years ago. So she also complains of some joint pain and swelling and morning stiffness with bilateral otalgia and hearing loss. And here we have an axial contrast-enhanced CT image at the level of the parotid glands, and you can take a look at them. Let's go on to the next set of images. Here are some ultrasound images of both of the parotids, well, representative images in longitudinal and axial. You can see some cystic changes. Next slide, please. Here we have MR images in coronal plane. The first one being T1 weighted without contrast. The second one is T2 with fat suppression. And the third one is T1 post contrast with fat suppression as well. All right, let's go on to the next slide. So what is the diagnosis? Is this cystic lymphadenopathy? Is this Sjogren's syndrome, Warthin's tumor, or is it benign lymphoepithelial cysts of HIV? Let's go to the poll. All right, 100% for, things are changing. We're getting some other votes. Excellent. All right, we're seeing things go back and forth a little bit, Okay. All right, let's go on to the next slide. And the vast majority again wins. Excellent job. This is Sjogren's syndrome. Next slide, please. So Sjogren's syndrome is also known as Zika syndrome, and it's characterized by dry eye and dry mouth symptoms, and it's because of this chronic autoimmune inflammatory process that generally attacks the lacrimal glands and the salivary glands. Sjogren's syndrome may also present with arthritis, pneumonitis, vasculitis, as well as nephritis. You notice the itis in all these names, right? Because it's a systemic inflammatory disorder. In the parotid glands, early on, you will see symmetric bilateral parotid enlargement and enhancement that's compatible with early inflammatory changes. But in the later phase, this is what you see. It becomes this multicystic appearance with punctate calcifications. And this can actually overlap in imaging features with benign lymphoepithelial cystic changes in HIV. But this is where that history and other symptoms of the patient really comes in to help you make the diagnosis. Thank you so much. All right.
All right, thank you, Dr. Wu. Can we have the next slide, please? Okay, so, hi everyone. My name is and again, that's Dr. Saeed. Hello, Jamie. I hope I pronounced it correctly. He's an associate professor of radiology and nuclear medicine at the Medical University of South Carolina, and he will be taking us through a couple of interesting cases of nuclear medicine. Thank you, Dr. Saeed.
Thank you for this introduction. So let's go ahead and do the nukes cases. So case number 1, this is a 35-day-old female infant presenting with dark urine, pale stools, and jaundice. Here we have dynamic 60-minute HIDA images. Next. Along with 4 and 24 hours delayed static images. Next. So what is the likely diagnosis? Is it biliary atresia, choledochal cyst, or neonatal hepatitis? Can start the poll. Okay, looks majority had biliary atresia and some of you has neonatal hepatitis. So let's go to the next slide. So the correct answer is biliary atresia. So what we see in this case is delayed clearance of hepatic activity, which is marked with a black arrow, with absence of bowel visualization at 24 hours, which would be most concerning in the setting for biliary atresia. Note that in cases of hepatic dysfunction, you might see renal and urinary bladder excretion, which should not be confused with bowel activity. For example, you can see in this case, which some of you may have thought it's bowel, some urinary bladder activity, which we are marking with the blue circle. Next. So in patients with neonatal jaundice, HIDA is going to be super helpful to stratify which patients would need biopsy and which would not. If you see radiotracer excretion into the bowel, as we are showing you here in this companion case, then this essentially would exclude biliary atresia and would favor hepatitis. But if you don't see bowel excretion, then this would be most concerning for biliary atresia, but it's not 100% specific. So other less common condition may cause this, including severe hepatitis. They may have this appearance on HIDA. So biopsy is needed to confirm. Retreating the patient with phenobarbital and extending the imaging to 24 hours are important to avoid false positive scans. Next. Case number 2. This is a 29-year-old male presenting with seizures despite being on anti-epileptic medication. Here we have axial T2 and coronal T2 and FLAIR images of the brain. Next. We're also showing you axial and coronal FTG PET images of the brain. Next. So based on these images, what do you guys think is likely diagnosis? Is it hyperglycemia, mesial temporal sclerosis, amyloid angiopathy, or artifact due to motion of the patient during the scan? Go ahead and enter your answers. Next. So looks like we have a strong Nukes audience today. So that's excellent job. That's the correct answer. So the correct answer is mesial temporal sclerosis. Next. So mesial temporal sclerosis, which is also known as hippocampal sclerosis, is the most common cause of temporal epilepsy. The imaging findings, which are nicely demonstrated in this case, include volume loss on anatomic imaging and increased T2 FLAIR MRI signal in the affected temporal lobe on MRI. On ictal SPECT, in which the patient is injected while they are having the seizure, you expect to see increased activity in the affected temporal lobe as the seizure emanates from this area. While if you're doing interictal SPECT or PET, as in this case, which are obtained in between seizures, you would expect to see decreased activity, which is marked with the yellow arrow in this image. Note that you may also see contralateral decreased activity in the cerebellar lobe, which we are marking with a blue arrow, and this is a reactive phenomenon related to cross-cerebellar diaschisis. Thank you, everyone. Hope you enjoy the rest of the session.
Thank you very much, Dr. Saeed, for those cases. So moving on, we're going to have Dr. Kathy Phillips, who is an assistant professor at Vanderbilt University Medical Centers, also a medical director of ultrasound, and she will be taking us through some interesting OB-GYN cases. Dr. Kathy, thank you.
Thank you. And thank you for that warm introduction. I also want to thank Mariam Moshiri for her unbelievable guidance and creation of the case collection, as well as her mentorship to so many of us as part of the deputy editor crew. So next slide, please. Let's get started with case 1. This is a 42-year-old woman who's presenting with 5-year history of chronic left-sided abdominal pain, which has been worsening over the last month. What you'll see are 2 axial contrast-enhanced CT images. The first is at the level of the left renal vein, and the second is at the level of the left gonadal vein. Next slide, please. Additional images from that study lower in the pelvis in the axial plane, as well as in coronal, through the retroperitoneum, particularly on the left, continue to demonstrate some interesting findings. Next slide, please. The patient went on to have a left renal venogram, which we're seeing some subtraction angiography images of on the left, as well as a frontal image through the pelvis from that venogram as well. Next slide, please. So what's your diagnosis here? Is this pelvic venous congestion due to ovarian vein reflux? Is it ovarian vein reflux because the left renal vein has been compressed, aka nutcracker syndrome? Is there an arteriovenous malformation, or is it pelvic lymphadenopathy? Next slide. Wow, lots of change here. Wonderful. See some people changing their answers, perhaps. Great. I think we've reached a steady state. Next slide, please. You guys are correct. This is pelvic venous congestion due to ovarian vein reflux. Next slide. So this commonly affects multiparous women, particularly of the reproductive age, and it's thought to be due to incompetent venous valves leading to reflux of renal vein drainage or ovarian vein drainage into the ovarian vein and then subsequently into the pelvic veins, which become engorged. Note that these findings can be seen in patients even without symptoms. So what are you looking for? You're looking for greater than or equal to 4 ipsilateral parauterine veins that are dilated, or you're looking for an ovarian vein, which measures more than 8 millimeters in diameter. Frequently, these patients, because of the congestion, will have bridging arcuate vessels that traverse the myometrium. It can be seen particularly well with sonography. Okay, next case. All right, this is a 21-year-old woman presenting with oligomenorrhea as well as infertility. And here we have a coronal T2-weighted image, MRI image, the level of the pelvis. Next slide. As well as a T2-weighted axial image to the level of the cervix. Next slide. And then now a coronal contrast enhanced image, the abdomen and pelvis at the level of the kidneys. All right, next slide. So what's the diagnosis? Is this a unicornuate uterus? Is this a uterus didelphys, a bicornuate uterus, or a septate uterus? All right, next slide. Oh, 100%. Very strong OBGYN. Very good, guys. No takers for bicornuate uterus? All right, so next slide. Exactly right. This is a unicornuate uterus. Next slide, please. So this is a class 2 Müllerian duct anomaly, which is marked by a unilateral uterine canal as well as a single cervix. The MRI, as we see here, shows a small hemiuterus, which usually deviated to the side of the original Müllerian duct off midline. And there's varying classifications of the contralateral horn from present to completely absent. These are frequently associated with renal anomalies due to the shared embryologic origin from the Müllerian ducts. And these anomalies are present up to 40% of cases and can range anywhere from renal agenesis to cross-ectopia. And yeah, so always make sure you get additional imaging of the kidneys when you do identify a Müllerian duct anomaly. Thanks for playing.
Thank you so much, Dr. Kathy. So we're going to have Dr. Peshka Chaturvedi, who is from the University of Rochester Medical Center. She's also the assistant editor for pediatrics. And I mean, I have a bias for pediatrics, so it gives me great joy to welcome her to show us a couple of interesting cases. Dr. Peshka, thank you.
Thank you for the great introduction. Let's move on to the pediatric cases. So here's case 1. This 8-year-old female had a past medical history of chronic constipation, reflux, and emesis, and presents with acute bilious emesis and severe abdominal pain after upper endoscopy with biopsy. So we have 2 images from an upper GI, contrast upper GI, and then we have a single transverse ultrasound image of the upper abdomen. I would ask you to pay attention to this finding here and this finding here. Next slide, please. So here we have 3 contrast-enhanced CT images in the axial, coronal, and sagittal plane. And this is the finding that we need to pay attention to. Moving on to the next slide, please. So what is the diagnosis? Is this an intramural duodenal hematoma, midgut volvulus, enteric duplication cyst, or a duodenal web? Let's activate the poll. We can go back to the question slide. All right, poll slide, please. Okay, so there's quite a spread here. Majority of people think this is an intramural duodenal hematoma, but there are quite a few, actually there are, okay, so that changed very quickly. Enteric duplication cyst 31% and duodenal web 13%, no takers for midgut volvulus, so that's great. Next slide, please. So this is an intramural duodenal hematoma, which is very nicely documented on all these images. Next slide, please. So this usually presents with bilious vomiting and severe abdominal pain post-endoscopic biopsy, and there is an increased incidence if underlying coagulopathy is there. And usually these are managed conservatively, unlike penetrating duodenal trauma, which needs to go to surgery expeditiously. Next slide, please. So moving on to case 2. This male patient was born at 39 weeks via cesarean section to a 22-year-old G3P2 mother. There was a history of maternal marijuana use and group B streptococcus colonization, no familial genetic syndromes, no maternal diabetes. So here's 2 radiographs of the patient's torso. So I would ask you to pay attention to the vertebrae here and make sure that you are identifying normal vertebral morphology and a normal complement of vertebral bodies. Next slide, please. So here we have a sagittal ultrasound image of the spine. And again, this is what I would like you to look at. Pay attention to the conus medullaris and look at its configuration, and also pay attention to the vertebral bodies and make sure that, whether or not you have a normal complement of vertebrae. Moving on to the next slide, please. So here we have 2 sagittal MR images, a fat-suppressed T2 weighted image and a non-fat suppressed T1 weighted image. And again, these are the findings, the same findings that I would like you to pay attention to. The sacral spine, please pay attention to the terminus of the spinal cord, and move on to the next slide, please. So what do we think is the correct diagnosis? Do these findings represent a myelomeningocele, a tethered cord, diastematomyelia, or caudal regression syndrome? Let's activate the poll. All right. Let's go to the poll slide and see how everyone's answering. So the grand majority thinks it's caudal regression syndrome, and there's a small percentage of people who think this is a tethered cord or diastematomyelia, and no one's checked myelomeningocele so far. All right, next slide. So excellent work. Yes, this is caudal regression syndrome. As you can very nicely see, the inferior most sacral vertebrae are missing, and there is a blunted sort of club-like terminus of the spinal cord, or the conus medullaris is blunted and club-like. Moving on to the next slide. So here, this caudal regression syndrome, there is an increased incidence with maternal diabetes. This particular patient did not have a mother with diabetes. There is a range of severity. It can range from minimal agenesis of the inferior most sacral vertebrae to very profound lumbosacral agenesis. And there can be associated GI, GU, cardiac, and skeletal abnormalities. And there are syndromic associations, including the Bactel associations, Carrarino's syndrome, as well as the OEIS complex. So with this, we conclude the pediatric section. And thank you for playing, and thank you for being here this evening. And thank you very much to RSNA and to Dr. Moshiri.
Thank you to all of our deputy editors and other members of the editorial team for joining us and for putting this together. It has been a pleasure to work with all of you guys, and I'm so happy that we were able to do this. And thank you for the audience to participate and to play. Hopefully there will be more of these in other contexts coming from RSNA. Have a good night, everybody.